Go ahead, next slide. This is just a little bit about me. You heard about that. Go on. Okay. So, what is a seizure? Commonly understood, a seizure is something that, a seizure is something that disrupts the brain. It causes the body to shake or to stop. The body frozen and staring, to stare off like no one is home. Terms such as grand mal, petit mal, tonic-clonic seizures, absence seizures, all these terms essentially imply the same thing, to shake or to not. Next slide. So, unfortunately, epilepsy and its seizures aren't so binary. It's not one or the other. The multitude of manifestations are limited only by the function of the brain. A binary either-or understanding of epilepsy prevents the recognition of many seizure manifestations and allows for the continual suffering of many people, sometimes with staggering effects. Next slide. So here are two examples of what can happen when we do not possess a more thorough understanding of epilepsy and its seizures. I once met a middle-aged woman who had these sudden episodes of abdominal pain, nausea, vomiting, that would go away as quickly as it came, only to reoccur a few hours later or a few days later. She went through numerous investigative procedures of her abdomen. Minimally abnormal findings were aggressively treated in attempts to alleviate her cycles of profound discomfort. What ended up happening is that she received numerous intra-abdominal surgeries, including a total hysterectomy with removal of ovaries, gallbladder removal, appendectomy, and even a partial bowel resection, none of which helped at all. After around 30 years, the patient was diagnosed to have autonomic seizures, and with appropriate treatment of epileptic medication, anti-epileptic medication, she no longer suffers. I met a young man who spent 2 years of his life with upwards of 20 unusual events, 20 unusual events a day. So he would suddenly jump up and sort of run around, repeating phrases such as "I love you, I love you," and at times inappropriately touching other people. These events were brief, and then he was back to his normal self without any recollection of just what just happened. So desperate to find help, he was told by multiple professionals from multiple states that he was either mentally unstable or he was on drugs. This young man who was once committed to a Seattle hospital psychiatric ward for suffering from hyperkinetic seizures. After proper diagnosis and appropriate treatment, his seizures are now coming under control. But he struggles with knowing that he lost 2 years of his life to a disease that thoroughly embarrassed him and damaged his reputation. So for this talk, I'd like to provide some background on seizures and then go over some other epileptic seizures that are formally recognized by epilepsy experts, but frequently go unrecognized by the general medical community. Not all, though. My hope is to broaden our awareness of epilepsy so more needless suffering may end. Next slide. So a formal definition. A seizure is defined as defined by the International League Against Epilepsy, is a transient occurrence, it's a transient occurrence of sign or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Next slide. All right, go ahead. Next slide. So, so to break that down, it's a transient occurrence. Okay, it comes and goes, and if the patient has epilepsy, the seizures will continue to come and go. The seizure occurrences are composed of signs, and signs are basically what other people see. It's objective knowledge of the seizure, and or symptoms, right? Which is what the patient experiences. All these signs and or symptoms result from abnormal electrical activity in the brain. Next slide. So the brain is the organ of consciousness. The brain, without any moving parts, uses chemistry and electricity to create all that we dream, imagine, do, and experience, including memory, love, empathy, bodily movement, planning, bodily sensations, what we hear, taste, smell, see, think, enjoy, and so on. And unconsciously, rather unconsciously, the brain also regulates heart function, respiration, defecation, urination, pupil size, fear. Anyway, the list goes on and on. But we have overwhelming evidence that the brain is not some mass like mashed potatoes. That by some magic does all these things and more. By studying what happens when pieces of the brain are destroyed and what happens when parts of the brain are activated by electricity, we know that certain parts correlate with certain aspects of our human experience. Next slide. So brain mapping. So these are some leads that are placed directly upon an awake brain during surgery to remove a tumor. I believe during this case we were mapping out the language area on the patient in order for the surgeons to avoid the area to avoid the language area, thereby avoiding resultant language impairment. See, tumors tend to shift the brain around, especially after a craniotomy. So once you remove the skull, it even shifts more. So a speech therapist assisted us during the surgery and performed a language analysis while we attempted to disrupt the patient's speech using electricity sent through those 3 white electrodes that you see. So I've been involved in other cases where we use this is called electrocorticography, where we used electricity to map out motor function as well as language. Next slide, please. So so this is a homunculus. So if we provided a pulsating electrical current to some of the motor cortex, so let's say we're right over here, and we just provided some pulsating electrical current to this area, it would cause rhythmic hand contractions to the frequency of the electrical pulse. Okay, and if you move it just a little bit, see, that's the hand area right there. If you move it a little bit down this way, then the face would start contracting at the same frequency. Right? So this is the face area. So remember that abnormal electrical neuronal activity causes seizures. A seizure could start here, and causing this to move, and then it would spread, causing the face to move or expand, and so you'd eventually have the face and hand moving at the same frequency, synchronously. It could also move this way, where you have the that's the motor. If you could also move this way, more posterior, and get to the somatosensory cortex, and then maybe the part of the face that's twitching would start to feel strange. So essentially, the Jacksonian march, which is where you have a seizure starting, here at the motor cortex, at the, let's say, hand, and it just spreads up here, so the hand, the arm, face, leg, it just sort of spreads according to this homunculus that you see here, was described by John Hewlings Jackson during the 1870s. And it shows how the seizure activates different parts of the brain as it simultaneously moves those parts of the body. The corresponding muscles contract with the same frequency as the oscillating electrical frequency seen on EEG. The EEG is a recording of the electrical activity of the brain. If the frequency is very fast, the affected limb stiffens. As the frequency slows, the muscles visibly contract. The stiffening of the limbs is referred to as tonic contractions, right? So it becomes tonic. And as the frequencies in the brain slow down over this area, you start seeing visible muscle contractions that we call clonic shaking. And it's often described in seizures. So likewise, if a seizure began in the somatosensory cortex, the patient may get a strange feeling in the corresponding body region. They may feel that odd sensation spread across the body as the abnormal electrical activity spreads across the corresponding regions of the brain that we just saw in that homunculus, for instance. A person may commonly experience tingling, numbness, or it might provoke a sense of movement, like twitching or the desire to move, bodily pain, perhaps a hot or cold sensation. As the seizure evolves, spreading across the brain and changes electrically, the tingling feeling in the face may become a sense of movement in the face or a sense of distortion. As the motor cortex is right next to the sensory cortex, the seizure can spread to that area and cause movement. So you might start feeling this hot or cold sensation, and that'll be followed by rhythmic contractions of that same region because they're right next door to each other in the brain. These seizures usually last about 30 to 120 seconds, and actually may sometimes be triggered by tapping or moving part of the body where the seizure originates in the corresponding brain region, or that corresponding region where the seizure starts, which is known as the focus, or where a focal seizure starts, the epileptogenic focus. Next slide, please. So, if the seizure focus is localized to the primary auditory cortex, the patient will hear something that's not there. The epileptogenic focus is where the seizure begins. Usually corresponds to a region where there had been some brain damage or some other reason for that part of the brain to become dysfunctional. A person with focal seizures emanating from the auditory cortex will hear will hear sounds emanating from one or both ears. They may hear a buzzing or humming sound. They may hear voices or music. Sometimes a plugging of the ears, like they lost the ability to hear. Unlike psychosis, these auditory hallucinations are brief, stereotyped, they're the same each time, and don't have the significant emotional content of psychosis. As with other focal seizures, the seizure may spread and activate other parts of the brain. So these arrows demonstrate this spreading of neuronal activity. That's synchronous neuronal activity. And as it spreads, it'll activate other parts of the brain. So right over here, you have the somatosensory area, the face, and then the motor area. If we go over here, we'll get to the temporal lobe, and so the seizure evolves, and which is why some people will call the auditory hallucination an aura, which is basically a warning of an oncoming seizure. Yet, what it really is the onset of the seizure. Next slide. Focal seizures can similarly cause a person to taste something that is not there. The taste is commonly unpleasant, is usually described as tasting metallic, rusty, bitter, or salty. Next slide. They also can cause people to smell things that aren't there. The perception is usually brief, often vaguely familiar, and commonly unpleasant. These seizures are difficult to localize and have been associated within the more central regions of the brain that are associated with emotions and memory. Next slide. So epileptic visual hallucinations occur when the abnormal neuronal activity involves the primary visual motor cortex, which is this back side of the brain. Or it could be the neuronal, or the seizure could be affecting the more anterior visual association cortex. So these hallucinations can be more prolonged than what we've talked about earlier. And they can either be composed of elementary things like dots, lines, simple shapes, and sometimes more elaborate things like a fully formed object, an animal, or just a whole scenery, like a whole landscape. Sometimes the visual hallucination will distort the patient's vision. Go ahead, next slide. And cause illusions. Epileptic visual hallucinations can last quite a while and can at times occur in isolation, and they also can spread and activate other regions of the brain. That last MRI was of someone that suffered from a brain bleed and later developed epileptic visual hallucinations. Okay. So this is a patient's drawing of what she sees during an epileptic visual hallucination. Right over here, this demonstrates sort of this magnification of the right side of the face. These dots are the hair pores that are sort of magnified. And on this side, the patient's drawing shows a list of the unformed or sort of hallucinations, the real simple things that can occur during a seizure. So focal vertiginous seizures. So abnormal, excessive synchronous neuronal activity in the posterior superior temporal gyrus, right there, will cause a patient to feel this sudden onset of turning, or rather vertigo, lasting seconds. Due to its location, go ahead, next slide. See, it's right next to here. It's often associated with an auditory hallucination. As these seizures will evolve and affect the surrounding brain region. Next slide, please. Autonomic seizures. So the autonomic nervous system basically regulates our internal organs, including the heart, sweat glands, our neuroendocrine system, and pain modulation, and so on. Seizures affecting the central autonomic network, which includes the hypothalamus, the insula, which contains the primary sort of visceral sensory cortex, where sensation of all the internal organs are mapped out in a way. The periaqueductal gray of the midbrain, which is involved in pain perception, stress, and reproductive behaviors. The pontine region involved in salivation, cardiovascular activity, the gut activity, respiration, thermoregulation. Anyhow, the central autonomic network, which you can sort of see here, it's very complex. It's a very tightly connected network, and receiving and providing reciprocal innervation to the organs involved. But in the autonomic seizures occur when are often associated when seizures occur within the mesial temporal. Can you go to the next slide? Yeah. So the mesial temporal lobe structures, or the operculum or insula, which is right there. So you see we're kind of like within the same sort of region. Okay. Of note, most people with autonomic seizures will, as I mentioned before, they'll feel this sudden, let's say, abdominal pain or this weird sensation. But they'll usually have normal gastrointestinal function between attacks. Go ahead, next slide. Gelastic seizures. So this is involuntary laughter. Consciousness may be preserved during these seizures. They're very brief. Some people feel embarrassed, while others report that it's pleasant. So cases of gelastic status epilepticus have been reported, which could be imagined as this endless, uncomfortable, involuntary laughter. And what I think is most remarkable is that when we place depth electrodes, we find into this seizure, into this region, we find that the hamartoma itself, which is posted out here, so it's usually caused by this hamartoma, which in itself is is actually causing the abnormal electrical activity itself. The hamartoma is a benign focal malformation. It's composed of tissues of the surrounding region, but it grows in this sort of disorganized mass. Next slide. So focal hyperkinetic seizures. Okay, so these are seizures that involve this region in general. Typically, the seizure will start with a sudden manifestation of excessive and bizarre behavior, such as the patient jumping out of the bed. You might see bicycling leg movements or flailing arm movements. The movement is often well organized. Vocalizations can occur, and it may be complex and understandable. Sexual behavior is not uncommon. Consciousness may or may not be preserved, but once this brief epileptic seizure is over, the patients are most often unimpaired. Sometimes tonic posturing can be a sign, but not always. These seizures tend to cluster and mainly happen in sleep. The seizure activity localizes to this region. And that region is typically where we find that complex behavior patterns are formed. Complex cognitive behavior occurs here, and the region is generally associated with personality, moderating social behavior. It's also called, the sort of the executive center. Next slide. Reflex seizures. So these are seizures that objectively and consistently demonstrate to be evoked by a specific stimulus or activity of the patient. The stimulus or activity can be simple or elaborate. The seizures, like a simple example would be flashing lights, a startle, some sort of monotonous tone. And then a more elaborate activity could be reading, listening to music, doing arithmetic, eating, walking. Anyhow, they're also involved sometimes brushing your teeth, even touching warm water can cause these seizures. The seizures types that are provoked by these reflex seizures are numerous and include full body jerks, loss of muscle tone, loss of consciousness, focal motor seizures, sensory seizures, impairment of consciousness. Essentially, this concludes my talk. What I wanted to sort of bring to awareness is that this binary understanding of epilepsy being something that shakes or not prevents the recognition of many seizures and allows for continual suffering of people with sometimes staggering consequences. I wanted to we went over the formal definition of seizures, and that the brain is an organ of consciousness, and that sort of that has different neural correlates of consciousness, sort of topographically arranged, and a seizure, and the multitude of different epileptic manifestations are limited only by the myriad functions of the brain. Next slide. Thank you.
I once saw a patient that only had seizures when she rolled dice. True story. We monitored her all day long. Normal, normal, normal. She picked up some dice with her mother to play Yahtzee, and she shook it, stared. Classic 3 Hz spike and slow wave complexes while she was rolling the dice. When it fell out of her hand, hit the board, she resumed her activity. It happened over and over again. Only rolling dice. That's the only time it ever happened. Yeah, it was the oddest thing. I thought there was something else going on other than epilepsy, but you can absolutely get fooled on those things. And have you ever seen hot water epilepsy? We were talking about that. It's pretty rare, but there's lots of great videos of it on the internet. Yeah, but it's always been a fascinating one. Where would the origin be from hot water? The somatosensory cortex? I don't know either. I was just curious. Yeah, it's kind of. Anybody else?
It's just fascinating, the different, variations of these behaviors and seizures and whatnot. How, however, with different manifestations, would one even approach diagnosis or assisting somebody to get the medical care that they need?
Well, I think you start with something like this. You start, bringing awareness to the subject, to entertain the possibility that these episodic, very brief symptoms might be something other than, let's say, dysfunction of the abdomen, right? And if we go and look, and it looks normal, right, and everything seems, the patient feels normal in between attacks, But that should raise some red flags that maybe we're dealing with something that's centrally located in the brain. That's more manifestation of how we're sensing and not what we're sensing. Is that? We just have to, yeah. So it's by raising awareness, and then essentially we do testing, and figure that out.
What type of testing? Because I'm
Well,
in the mental health field, and someone who has spent a year of, it sounds just like the patient you talked about with abdominal pain, of tests and specialists and such.
Well, you'd start with a thorough clinical evaluation, and then you may need an EEG. It'd be good to confirm the diagnosis. You also can empirically treat. Does that answer your question? Yeah. Okay.
So complicated.
Yeah, I mean, you get MRI and see if there's a lesion that would correspond to the region of the brain that could be responsible for that symptom. Yeah.
Yeah, and have you heard of anything about eating disorders related to seizures?
Can you repeat the question?
Eating disorders related to seizures. I'm sure it exists. But I don't have. I haven't seen it, but I can definitely see how that could be a possibility. Good. Oh yeah, that's true. Yeah, that's a good point. Well, yeah. So you're saying the medication might be causing an eating disorder.
But also you can have some, if you're having seizure activity that is affecting swallowing ability to swallow or to that effect.
Yeah, I've seen patients that would just, their seizure manifestation would be that they would light a cigarette and go outside and then come back inside and put the cigarette out. I mean, anything the brain does, a seizure can reproduce. I think that's really the takeaway point that I'm trying to make here. So of course you could eat and eat,
Are there any other questions? All right, well, thank you so much, Dr. Buckland.
Thank you very much.